Good morning, everyone, and thank you for coming to Date with a Cure. I'm Eugenia Welch, president of Alzheimer's San Diego. Today, you'll have the special opportunity to hear about the latest in Alzheimer's research directly from the scientists working to find a cure. A link to today's agenda and the speakers' biographies have been entered into the chat. You can pull that up and follow along as we go. On that note, I'd like to recognize and thank our esteemed panel for being a part of this event. I want to thank our presenting sponsor, the Sharp Neurocognitive Research Center, as well as our co-sponsors, Elector, Keck School of Medicine of USC Alzheimer's Therapeutic Research Institute, Pacific Research Network, and Advanced Brain Monitoring. Now I'd like to tell you a little bit about our organization. Alzheimer's San Diego is a 100% local, independent nonprofit committed to serving the needs of the San Diego community. Our mission is to enhance the quality of life for those affected by dementia in San Diego County through supportive services, education, social connections, and community awareness. People living with dementia and their care partners can meet one-on-one with a dementia expert via phone, email, or in person to receive supportive counseling. We offer online and in-person education in English and in Spanish on topics ranging from Dementia 101 to communication skills, preparing for the late stage, and much more. We have 35 support groups for care partners to choose from, both in person and online. These groups provide care partners with the opportunity to discuss caregiving challenges in a safe setting with other people who are going through similar situations. We offer opportunities for socialization, respite, and individual support through our weekly social activities and community outings. Our Vitals program helps to support the 25% of San Diegans living with dementia who also live alone. And our All's Companions respite program provides care partners with a much needed break. All of these life-changing programs are provided free of charge to the community thanks to the generosity of our donors. And finally, we continue to support local research by educating the community about the importance of clinical trials and matching people with clinical trials. As I've mentioned, all of the services we provide are 100% free of charge. We are completely supported by the generosity of our community, which is so critical as we work to support the growing number of those impacted by dementia. Two of our biggest fundraisers of the year are coming up: our annual motorcycle ride, Rides for Alls, and of course, our annual walk, the Walk for Alls, which we've held for years in beautiful Balboa Park. Whether you prefer to cruise through the streets of San Diego or walk in Balboa Park, I'm hoping all of you here today will sign up for one of these amazing events. You can learn more about both events at the links in the chat field. The most current numbers available to us say that there are nearly 100,000 San Diegans living with Alzheimer's or another dementia. And as I said earlier, 25% of those diagnosed live alone. That's 25,000 of our neighbors diagnosed with Alzheimer's or another dementia living alone. And unfortunately, we know there are many more people struggling who have not officially been diagnosed. The impacts of dementia are felt across all demographics and impacts all walks of life, including the almost 300,000 family and friends who are unpaid caregivers. This is why it's so crucial that we find a cure. Progress towards a cure is what we're here today to hear about. So let's get started. It's my great pleasure to introduce today's moderator, Marcella Lee. She's sure to be a familiar face from her role as anchor of the 5 p.m., 6 p.m., and 11 p.m. news on CBS 8. Marcella is also a great friend to Alzheimer's San Diego and has worked hard to raise awareness and educate the community about Alzheimer's and dementias. And I have to share, Marcella is also the proud mother of twin high school graduates. So we're grateful that she has the time to spend with us here today. So Marcella, take it away.
Thank you so much for that warm welcome, Eugenia. It's so great to be back here this morning. I believe it's my third date with a cure, and each year I learn so much from the esteemed panelists who are here to take their time and share their insight, research, knowledge. It's just an incredible morning, and I'm so glad that all of you have made time to come to join us for the next couple of hours. Today's program is being broadcast using Zoom webinar, so everyone is muted to reduce background noise and distractions, but we very much want for you to ask questions. We want you to participate. And to help us keep track of questions, there is a questions and answers feature in the Zoom. You see the slide right here. When you click on that button labeled Q&A in your control panel, it will pop up a box, and that's where you can type your questions into. And it's great because really this is a unique opportunity for you to ask your questions, and then I'll help moderate and ask our experts for you to get the answers. Please keep those questions limited to that Q&A box because that's what we will be monitoring. There's also a chat function where we'll send materials and links. We'll share those with you in the chat function. Also, closed captioning is available. Just click on the Show Captions button in your control panel to turn it on. I know it's a lot of technology, but we've done this for a few years and it works really well. This program is being recorded, and a link to this video will be shared early next week. So if you need to pop in or pop out, or you are feeling like you need to jot some notes down, don't worry. You can always come back and watch the 2-hour broadcast. All right, I know how important this event is and how many questions you have. It really can be hard separating fact from fiction. Delighted to give you the chance to get your questions answered directly by these amazing experts. The researchers on this panel are truly extraordinary. They are the reason that a cure for dementia could very well be found right here in San Diego County. Every year we hear about more advancements. I'd like to introduce our panelists. Dr. James Brewer, Director of UCSD's Shiley Marcos Alzheimer's Disease Research Center. Dr. Michael Plopper, Medical Director of Sharp Clinical Research Center. Dr. Sherry Sefji, CFO and Medical Director of Excel Research. Dr. Hector M. Gonzalez, Professor of Neurosciences, UCSD School of Medicine. Dr. Gerald Chun, Senior Vice President, Neuroscience Drug Discovery at Sanford Burnham Prebys Medical Discovery Institute. Dr. Douglas Galasco, neurologist and professor of neurosciences at UCSD, and Dr. Doris Molina Henry, assistant professor of research, Department of Neurology, USC Keck School of Medicine's Alzheimer's Therapeutic Research Institute. Okay, everyone who has joined us, this is your chance to get your questions answered directly from some of the most renowned scientists, not only here in San Diego or Southern California, but in the entire world. So what a great opportunity. Okay, let's get started. As we wait for those text questions to come in, I would like to open it up to the panelists. Is there something remarkable, something new in the forefront that we haven't yet discussed since we met here about a year ago? Dr. Brewer, would you like to start?
Thank you very much for letting me lead off, because there's a lot of exciting stuff going on, and just happy to be here and sharing this news with the community and my colleagues here, and it's great to be here again. One of the hot off the presses topics that just happened yesterday was a voting of the FDA panel for another anti-amyloid medication, donanemab from Lilly. And it'll give us more options to be providing treatment to our patients at the early stages of disease. This is really a breakthrough that's just been very exciting in the last year, including some new presentations about the benefits of starting this medication as early as possible. New biomarkers have really pushed this field forward, the ability to detect the two main bad proteins of Alzheimer's disease, amyloid and tau. And this research has been really remarkable and exciting. Seeing that when an individual has the amyloid in their brain, but it's only beginning to build the tau in the brain, that might be the ideal period to start treatment. So very exciting time. There's a lot we can delve into these 2 hours.
I think many people may have read the headlines yesterday. Does anyone else want to weigh in on, I know when my mom was diagnosed in 2019, so 5 years ago, when I met Eugenia, she said that it had been decades since, a drug was developed that was effective in treating Alzheimer's. And just in the last 5 years, I feel like we've been announcing every few months about new medication, new therapies, new treatment. It's really exciting.
Hi, Marcella. Maybe I'll add that I think that along with what Dr. Brewer alluded to, one of the really exciting things about this is that it's really highlighted a pathway that works. And I think that that offers an opportunity for us to identify multiple ways in which to tackle that pathway and further understand when it doesn't seem to work for some particular populations, the directions that we need to go in. And it really has begun to open doors to understanding the disease pathology, the stages of the disease at which you can intervene that are much more effective. And I believe that in the field as a whole, what we're beginning to see is just so many different ways of tackling this problem with much more hope and much more excitement, because we are seeing so much happening and turning into a positive outcome.
I know that a lot of people like me, who are children of people who've been diagnosed with Alzheimer's, are concerned about our future. And that's why this research is so exciting, and the different advancements. But I know the drug my mom took, Aricept, or Namenda, a lot of people are on those. Are there any updates to those drugs? Who would like to answer this question?
I'll jump in. Unfortunately, there are no newer drugs besides Aricept and Namenda. There are a number of alternatives to Aricept that work through the same mechanism or pathway. And this is an area we've been struggling with to try to come up with treatments that will improve the symptoms once somebody has an already established dementia. It's obviously a hard problem, otherwise we would have solved it years ago. And there are ongoing efforts in this space and a number of ongoing clinical trials. We'll have to be patient and see what comes up.
We do have questions starting to come in from our audience, and we do encourage you, if you're joining us, to go ahead and type your questions into the Q&A panel. This is really an amazing opportunity to get your questions answered. So from Brandon Felt, has UCSD established a pathway for patients diagnosed with MCI or unspecified dementia to undergo genetic testing, either within the clinic or in a research setting?
Again, I can answer that. So genetic testing is done for very specific reasons. If people are going to be considered for one of the anti-amyloid treatments with some of the new antibodies, Leqembi is the one that's currently available, we need to perform genetic testing for ApoE or ApoE4 because this modifies the risk of treatment. Otherwise, we don't do genetic testing on a routine basis in Alzheimer's disease, unless we have the very rare circumstance where somebody comes from a family with multiple people who are affected and a very young age at onset. By very young, I would say usually younger than 50. Otherwise, there really isn't a value at this stage in genetic testing on a widespread basis. We are conducting a lot of research studies on genetics to try and figure out as best as we can what the genetic background is for Alzheimer's and whether this may give us some clues towards potentially personalized medicine or new opportunities for treatment.
And following up on that, what do you recommend as far as being tested for genetic cognitive decline, rather? Not just the primary test that I know, like I took my mom to get from her primary physician, but when relatives are noticing, even the patients themselves, greatly decline cognitive function, should you just go in right away? Who would like to address that question? What's the next step? I know it's very scary and frightening for a lot of people to take that next step.
Michael, maybe, or I'm happy to take it if otherwise, but I think Doug and I have been. Go ahead, Michael.
I can take that one. Say that question again, Marcella. I'm sorry.
Just I feel like when people start realizing that it may be more than just, oh, I've misplaced my keys, and when they become concerned, when family members become concerned that there's a more serious issue, what do you recommend to get tested for that actual cognitive decline? Like, what's the next step past your primary care physician?
Well, the next step would be referral to a specialist, principally a neurologist, possibly a geriatric psychiatrist, to do an MRI scan, look for any structural changes which might explain the cognitive problems or other explanations. For a person who, and then perhaps some cognitive testing to further define the areas of cognitive loss. But for a person who is going to be potentially starting one of the new treatments, it's necessary to do a couple of things, one of which is a PET scan of the brain to determine whether or not amyloid is present. There's no point in giving an amyloid lowering medication if you can't prove that there's sufficient amyloid to warrant doing that. So a PET scan of the brain would be key. Medicare is now paying for those in order to help people qualify for the new medications. Genetic testing, as Dr. Glasgow had mentioned, is important in this regard, and that is the people with APOE4 and particularly 4/4 are more prone to the side effects of these new medications, and also have a differential sort of response, in part due to their ethnicity. And that is an especially important reason. I'll diverge here a little bit, but to have more diverse participants in our clinical trials, and that is there is a differential effect of APOE depending on the person's race. But we just don't understand that well enough yet to really operationalize that in terms of populations of people. So it's an important reason why diversity in trials as we conduct these trials is important. But back to the question, it's see a specialist and get started in the process. I think people defer this sometimes until it gets worse, and we really do want people into trials as early as possible in the disease course.
You know, I realized, different from past years, I just wanted to jump right in, but I typically start by having you introduce yourselves and talk about what you're studying. And that's why I was trying to figure out who's trying to answer what. And I realized that I forgot to even start with I'm so excited to jump right into the new advancements that I neglected to have you all introduce yourselves and just give a little bit of background of what it is that you're studying and what areas you're finding to be, really exciting in the last year, the developments, the advancements. Dr. Brewer, let's start with you.
Hi there. Thanks again. So James Brewer, a neurologist and director of the Shiley Marcos Alzheimer's Disease Research Center. I also chair the Department of Neurosciences at UC San Diego. So we've been very proud to set up a specialized memory disorders clinic here at UC San Diego. A lot of demand. We need to grow it for sure. And we're struggling to help reach as many of our San Diego colleagues as possible. So thanks for having me.
Thank you. Dr. Melina Henry.
Good morning. Thank you, Marcela. It's a pleasure to be here. As you heard, I'm Doris Molina Henry. I'm an assistant professor at the Alzheimer's Therapeutic Research Institute, which is a part of the Keck School of Medicine at USC. A lot of our work is really devoted to ensuring that we can conduct timely and inclusive trials that allow us to have the developments that we are currently seeing. So we are a coordinating center that works with a number of sites and manages the Alzheimer's Clinical Trials Consortium, of which I am a co-lead for one of the units, the Recruitment, Engagement, and Retention Unit. So that really speaks to the type of work that I have devoted my career to, which is really the recruitment, engagement, and retention of participants in trials, and understanding the differences across populations. As Dr. Plopper alluded to, we begin to see differences that can contribute to less likelihood of being able to participate in a trial. And those are very much entrenched in some biological differences across different populations that may be simply attributed to background and life exposure. So we delve across that, the different dimensions of diversity in the populations in our studies. And right now, those are some of the studies that we are conducting as we constantly work towards getting the word out about participation and engaging individuals into studies.
Thank you, Dr. Molina-Henry. Dr. Sefji.
Good morning. I am a psychiatrist and I am a co-owner of Excel Research, where we do clinical trials on a variety of disorders, including Alzheimer's disease. I participated in some of the studies for the treatments and for trying to actually modify the course of Alzheimer's disease, as well as the studies for addressing the agitation that can come in some folks when they have Alzheimer's, especially in the later stages. I have not actually had the opportunity to participate in any of the studies on the new tests that are coming out. I would put in a plug also again for study participants. Someone had asked about treatments for the sundowner syndrome, which in clinical terms, I think is kind of what we refer to as the agitation in Alzheimer's. And several of those studies have floundered simply for lack of finding enough people to participate in the studies. And I certainly would not minimize the commitment and the time it requires to participate in the study, but unfortunately, if we can't actually find enough people to go into these studies to test the new medications, they can never get approved for actual use. And so, taking part in a clinical trial, we need folks to do that. It's a crucial part of drug development. And so I just would encourage people to consider doing that.
Thank you. Dr. Hector Gonzalez, good morning.
Yes, good morning to you, and thanks for having me back this second time to the Date with the Cure. It's a real pleasure to be here. So I'm a neuropsychologist by training. So as Michael mentioned a few seconds ago, the guy who would do the cognitive testing. I'm not really in practice these days, but that's what my history is. More recently, I describe myself as a population neuroscientist here at UCSD, and I'm also at the Shiley Marcus Alzheimer's Disease Research Center, along with Dr. Brewer, my good colleague and friend. And but the study that I'm doing, since you had asked, is the largest study of diverse Latinos and Hispanics here in the United States. We have enrolled over 16,000 Latinos across the country. Have done some extensive cardiovascular and cardiometabolic phenotyping testing of this population. And the study that I lead in particular is called the Study of Latinos Investigation of Neurocognitive Aging. It's a mouthful, so we just say SOLINCA, and you may hear me mention that again. We've been on this trail for probably now 14 years since the study actually started. And as our cohort, our thousands of participants, many of them are here in San Diego. I failed to mention that we have sites in Bronx, New York, Chicago, Illinois, Miami, Florida, and of course here in San Diego. And some of our audience may be participants. And if you are, thank you for your participation. It really makes a difference. This is a population that is poorly understood. I think with regard to the treatments that are emerging, I agree with Dr. Molina-Henry. We need more involvement, and also Dr. Plopper had alluded to this. And I think we need to understand how, and what we're defining is how cognitive change happens from your midlife. We started our study with people who are in their mid-40s, and how that progresses over the decades. And we're finding some interesting things, how the heart and metabolic systems are contributing to cognitive decline. And now we're looking at how some of these protein changes that Dr. Brewer and others have mentioned here may be emerging in later life. But the question we still have is, how does that happen? How does that key turn and the like? So I just wanted to throw that out there for some of the few things that I've been doing over the past 20 years plus as I've been in the field. And again, thanks for this opportunity to be here. The more I get involved with the Alzheimer's San Diego, the more I like, and the more I like to like what you all are doing. So thanks again.
Yes, Alzheimer's San Diego is wonderful. It was a wonderful resource for my mom. She did pass away in November, but not from Alzheimer's, from some liver complications. So what a great resource and friend Alzheimer's San Diego has been to me, my family, and I know so many people in San Diego's community, offering all services for free, 100% free. So we appreciate you. Okay, let's move to Dr. Douglas Galasco now. Good morning, Dr. Galasco.
Good morning. It's a great pleasure to be here. I am a neurologist, and I work at UC San Diego and in the Shiny Marcos ADRC for research. I also have a clinical practice through the Memory Disorders Clinic, and I have a number of different research interests, some of which involve bringing new therapies or testing new therapies in the hope that they can be brought into clinical practice. I also have an interest in biomarkers, trying to come up with novel tests to help with diagnosis. And I have an interest in some of the other kinds of disorders that can contribute to memory and cognitive loss, including Lewy body dementia, frontotemporal dementia, and vascular dementia. So lots of different things, and I'm very excited by the recent progress and the new therapeutic options that we have for Alzheimer's disease.
Thank you. Dr. Chun.
Yeah, thank you, Marcella. It's a pleasure to see you again and all of our colleagues here. Congratulations on your kids' graduation, a major milestone. It's been really, I think, an interesting journey to see all the changes that are going on in the clinical as well as basic science landscape. We're primarily basic scientists as we look at molecular changes in the brain, particularly those that occur somatically, which means that they are not passed on to your children, but instead are happening within your brain as you mature. You could almost think about it as a type of cancer that occurs not in all cells, but in some of your cells. And these types of somatic changes, we believe, may be part of a number of neurodegenerative diseases, including Alzheimer's disease. And one of the mechanisms that we've been looking at relate to a process known as reverse transcription. And many of you will know this from the HIV field, as well as even COVID, in that RNA viruses that are out there in the environment that naturally occur have within them a special protein, a special enzyme that can copy mRNAs and stick them back into DNA. And that's the name reverse transcriptase. And it turns out that our bodies and our brain are stuffed full of these reverse transcriptases, and that they can likely go awry. And there's been some recent data from post hoc studies looking at, say, over 200,000 individuals exposed to reverse transcriptase inhibitors that actually shows some protection or even some therapeutic aspects of this exposure. So it underscores that there's a lot more to look at in the therapeutic space beyond amyloid, which clearly has some type of detectable effect, but also has to be looked at in the context of both safety and long-term issues, as well as the larger patient population that will now be exposed to the amyloid treatments. And both Doug and Jim and Hector can comment on that further as well. In addition to our basic science lab at Sanford Burnham Prebys, I've embarked on an academic relationship and commercial relationship with Neurocrine Biosciences. Neurocrine, some of you may know as the building that's come up off of Route 56 And the goal there is to make more contacts with our academic colleagues across the Mesa and more broadly to bring meaningful therapies to patients. So it's an exciting time, both from the academic and commercial side. And I think there's going to be more and more opportunities to make an impact. And of course, I think Alzheimer's San Diego is central to that. And it's a pleasure to be part of that.
Thank you so much, Dr. Chun. Okay, and Dr. Michael Plopper from Sharp Clinical Research Center. Good morning. If you could just share a little bit about your background and what you're studying currently.
Good morning. Thank you, Marcella. I am currently the principal investigator for Sharp Neurocognitive Research Center. My history is that I've been the chief medical officer at Sharp Behavioral Health Services for 25 years. During that time, doing clinical trials in a variety of CNS agents, a variety of medications over those 25 years, and in the recent years, principally working on Alzheimer's disease. We did at Sharp Neurocognitive Research Center both the lecanemab trials and the donanemab registration trials. So we're very familiar with both of these agents over the past 7 years or so. Have been participating in these trials. We're very familiar with them, as well as their side effects, which do need to be talked about at some point during the conversation. But at any rate, we've been very actively involved in Alzheimer's research. I'm actually going to be retiring this summer, and so Dr. Paulette Cazares is going to replace me and take over our studies. So this will be my last date with a cure.
Aww. Well, we appreciate you joining and sharing your insight, and congratulations on a big, I don't know, milestone, I guess you could say. I think all of us look forward to retirement, but it's hard when you are involved in such instrumental research that could be doing so much good for so many people. So I applaud you for all the work you've done and for taking time to retire, because you look kind of young to retire. So
Thank you.
we're very proud and happy for you. Thank you so much. Okay, so I will ask the panelists now that we've done. So thank you so much. And I'm sorry that I just wanted to jump right in today. But I see that some of you are answering directly into the Q&A. So if there's something that you think you can type in there, that would be great. So for our audience, if you've asked a question, continue to check the Q&A box, because our panelists will be answering questions directly. We've already gone through about a half an hour, so you can see how quickly time flies. Let's start with Dr. Brewer answering a couple questions you've indicated. And panelists, if you see a question that you'd like to reply to, please indicate that so that I know to call on you. Let's answer a couple questions. When will blood tests be widely available? I know a couple years ago we talked about just a simple blood test being able to possibly diagnose or at least lead a patient down that path to investigating more about cognitive decline. And then another question, what is the new testing for biomarkers? How is it done, and is it covered by Medicare? So Dr. Brewer, I'll let you answer those.
I said I would like to test that. I would like to answer that, but I meant for Doug. I don't know where he is on your
Okay,
Doug is the
that's great.
world
Yes,
expert.
you answer for
Okay.
who you'd like to answer.
I said I
Dr.
would like
Gillespie.
Doug to answer that.
Okay, so there are a number of different biomarker test options for Alzheimer's disease. Dr. Plopper mentioned amyloid PET. A PET scan is a nuclear medicine scan of the brain, and that is covered by Medicare in the context of someone who may be eligible for treatment with lecanemab. It's not covered for any other particular reason. So if we wanted to order an amyloid PET as a general diagnostic, the patient would need to pay out of pocket. Another option is to do a lumbar puncture for CSF testing. We do quite a bit of this at UCSD. One of the reasons is that in addition to being able to test for biomarkers related to Alzheimer's, there is the very exciting development of a biomarker test in CSF for Lewy body disease and Parkinson's disease. And so from the same sample, we're able to send out tests for all of these different options. These are kind of subsidized. They're not fully covered by insurance at the moment. And then an emerging area, and some of these are kind of available, is blood tests for Alzheimer's disease. there are a number of different blood-based biomarkers. The most promising of these is called phospho-tau 217 or p-tau 217. And at the moment, this is not an FDA-approved test, but a number of companies and laboratories are offering testing with it. And the cost will vary somewhat, as I mentioned, not covered by insurance. It also is, while it's quite an accurate test, it still is under development, with the question of whether it should be used as a triage test. In other words, we can take certain cutoffs on the blood test to decide whether somebody definitely doesn't have amyloid or definitely does, and there will be a gray area in between. And for people who fall in the gray area, we will need to do some additional kind of test, either an amyloid PET or CSF testing. So this is still under development, but the arrival of blood testing is a very exciting opportunity.
And is that something that you would do, you know, like if I'm concerned, would I just go in at age 50, or is it something that you wouldn't do until you're starting to show symptoms?
So that's a great question. The availability of a blood test could unleash all sorts of possibilities. We would recommend that it should, at the moment, be done by someone who will be ordered by someone who has expertise in the assessment of people with cognitive disorders. So we'd like someone to have obtained a good assessment beforehand. We don't believe this is a risk biomarker, so we don't think that there's any point in getting it done if you're 40 or 50 years old and worried about the future. We think at the moment this is useful for somebody who may have very early symptoms to try and figure out if new treatment opportunities are appropriate for them or not.
Okay, thank you. This is an interesting question. You know, we're talking all about AI, artificial intelligence, and how it can really enhance a lot of things, but also quite frightening on other fronts. Have any of you experienced or have thoughts on how AI could help speed up the treatment or finding a cure for Alzheimer's? Or do we need really?
I will jump in then if nobody else is going to answer. We've been working on this for a very long time from the imaging standpoint. So looking at brain images to do more than just have the scanner show an unlabeled brain. We would use AI to understand which structures are most affected by the disease and what is the pattern that it reflects. So we made a lot of progress in segmenting the brain structures and measuring them and relate them to norms. That is fully AI based, but it's been way before the AI revolution. So as AI is enhanced, we think that's even going to go further. And it's nice that the FDA is now starting to accept that sort of a concept beyond just the rigor that they applied to approval of new approaches. So the FDA is allowing more advances, even though it is a little black box type of process, but we know that they work, and the FDA has begun to understand that sort of advance shouldn't be held back, even though they may not fully understand where the AI algorithm is getting the answers. So it's going to be an exciting time, at least from the imaging standpoint. And I think we'll clearly be able to take a full set of data coming from the patient-doctor interaction. In fact, even a live assessment of what's going on even in the exam room, and pull that together with all the other data, the cognitive testing, the imaging testing, the blood biomarkers potentially, and do things that we in our minds wouldn't have the time or the ability to link together to make the full assessment. So it's going to be an exciting time, I think.
That's really neat. I like that perspective. Let's go to this next question from Lisa Hykoff, and I'll address it to Dr. Glasgow, since you mentioned Lewy body vascular dementia. She's asking if there are any updates regarding treatment for those.
So at the moment, we don't have new approved drugs for either vascular dementia or Lewy body dementia. There are a number of clinical trials in progress for Lewy body dementia. The area is receiving a whole lot more attention than it used to. And there may be a trial, since many people with Lewy body dementia also have amyloid build up in their brains. There will be a trial most likely next year looking at whether anti-amyloid therapy could have an impact on people who have Lewy body dementia. For vascular dementia, again, there are clinical trials in progress. The major kind of finding which came out a few years ago was that really good control of blood pressure in people in their 70s and older could have an impact on cognition and on the MRI appearances that we find in people who have vascular dementia. This was called the SPRINT study, and the cognitive component was the SPRINT Mind study. So at the moment, looking at vascular risk and trying to modify all of the factors in an individual person is our approach.
That's great. A follow-up, just another attendee asked about specifically about vascular dementia, and do the new Alzheimer's medications work for vascular dementia, and are there side effects that might exacerbate vascular dementia?
No, I'll add one postscript to that from Dr. Glasgow's comments. It's the complex presentation of these diseases makes cubbyholing it as purely Alzheimer's disease versus vascular dementia versus FTD, et cetera, bit problematic in living patients. There was an interesting study from colleagues in Washington that looked at the brains of individuals that had died from, quote, Alzheimer's disease, and over 50% of them had a comorbidity, that is another disease in addition to the classical A-beta Alzheimer's disease. So that underscores that there are other mechanisms that can produce the dementia that may not be amyloid related, but because they are present at the same time, it'd be difficult to sort that out. So these complex presentations mean that some therapies may actually work, even though they're not supposed to work in a dementia, because you have this complex mixture of other mechanisms.
I want to take an opportunity to jump in as well and just offer some somewhat related to the vascular dementia question, which is a good question, I think. And that is, if somebody comes, this is getting back at the very beginning. Somebody has a complaint about changes in their cognition. They're not remembering things, or they're misplacing things. I think you alluded to, Marcella. This is fairly common, but when it becomes very common for that individual, I think it's very important to make sure that there's nothing else going on. We don't want to jump to the conclusion that there's Alzheimer's disease in the background. Somebody could have difficulties with their medications. Maybe their diabetes isn't well controlled, and I saw Ms. Estrada's question there. Also, and I do want to come back to that at some point, but I think there are these other conditions maybe that are causing a delirium that can be changed early on. So seeing a physician, getting a good set of testing, getting a good understanding what might be going on is to rule out the or to treat. Maybe their medications need to be adjusted, as I mentioned before. So I think we need to be very careful, make sure the person's healthy and otherwise functioning well before we jump into the treatment for Alzheimer's disease. Certainly don't want to miss something that's very important, very treatable today.
There's been a lot of questions about the link between diabetes and Alzheimer's. Are any of you?
I'm going to jump in there again, because I did mention the question by Ms. Estrada. Mm-hmm. And especially amongst Latinos, what we're seeing is that diabetes will double your risk amongst Latinos now for the mild cognitive impairment state, if you will. And we think that's important. Again, here's something that could be easily modified. We have treatments for diabetes, for controlling diabetes and blood sugars and the like, just like Doug mentioned about hypertension, we have these treatments available. We think that treating these early could be pathways to preventing these terrible diseases in later life. But we got to treat these earlier. Make sure that, because there is secondary damage to diabetes, to hypertension that happens to the vasculature that may relate to some of these changes in proteins that occur later in life. So I just wanted to jump in there and
Yeah,
comment.
that's really important. I think we all get busy and we wait until it's a little bit too late. And there have been a lot of questions in our Q&A about getting involved in the clinical trials. I think it's exciting, and I know that there's been a big push in trying to get more people to volunteer, to participate. And we know it's a big time commitment, and it's could, you know, be a little bit scary with the unknowns and the uncertainties, but I know a lot of you, if not all of you, are involved in clinical trials. Dr. Sefji, how can people, what are some of the tests that you're doing, and how can people get involved?
The best way, it's certainly calling one of the centers, you know, represented here today directly would be one way. You can actually see, excuse me, all of the clinical trials being done on the website clinicaltrials.gov, and you can search that. It is not the most user-friendly website out there because, you know, the studies are listed under different names, but if you type in dementia and or Alzheimer's and search, you can also search by your location, and it will tell you all the studies that are being done there and the sites that are doing them. And then you can call them directly and ask.
Someone did ask specifically like about location, North County or South County, because they say most seem to be in the La Jolla area, which, you know, can be difficult, especially I know I've been a caregiver for someone with Alzheimer's. Sometimes being in the car, sitting in traffic, traveling long distances gets, they get, you know, antsy and agitated. So in that clinical trial website, you can put in location.
Yeah, your zip code, I believe. And there are sites that are doing trials in other places. I mean, my office is located in North County. I don't actually know, I believe there is a site in South County. One of you involved with that can mention that location. But, you know, part of the reason why they are centralized around the medical centers is because there is a fair amount of testing involved in doing the studies, and the scanners that do the amyloid PET or amyloid tau PET scans or some of the other specific scans are not necessarily located in other places. So, and also, I mean, I think still the majority of the research is being done. It's like UCSD and some of the larger organizations. So it is unfortunate that, you know, I know that can be a drive, but again, there are other sites that are doing some of the studies in other parts of San Diego.
Can I add? I think,
Yes.
Thank you, Dr. Sefji, for sharing that. And I want to underscore that these are amazing ways to approach this. I personally am an avid supporter of reaching out to your local institution, a place where you already feel comfortable and that is within your distance. And it is a pathway to identify locations, sites. A lot of what we do through initiating participation via registry that can serve as a longitudinal study where people can actually get and evaluate their own cognition by completing cognitive assessments on a regular basis. And if individuals are likely to decline or show indication that they might be eligible for a trial, they might then be contacted. So finding these places where you can connect with the research network for these opportunities is an excellent way to go. I think it also provides the assurance of you're going to a place that is in your backyard, that is a location that's familiar and that likely has a site where a study is being conducted that will be a good match for you, and you would be a good match for that study.
And to just piggyback on that, I know when I was caring for my mom, you're just trying to get through the next hour, through the next day. So sometimes it's difficult. So for all of the people who are joining us today, I would encourage you to write down the names of these esteemed doctors and panelists and the institutions that they are affiliated with. And then you at least have a place to start where you can call if you're here in San Diego, these places. And sometimes there are satellite offices or doctors in different parts of the county doing the research, because I do understand the limitations for caregivers and patients themselves. There have been a lot of questions about the new drugs. So a few questions about lecanemab, and then people asking for you to explain more about the drug that we opened up this forum with that was just approved yesterday. So who would like to talk about lecanemab?
Sure, I'd be happy to jump in. So lecanemab was approved last year, and a number of centers around the country are now offering it as treatment. It is covered by Medicare, and it's an antibody that binds to a particular form of the amyloid protein and helps to remove it from the brain. It has to be given intravenously as an infusion every 2 weeks. The company is working on a subcutaneous form together with an auto-injector, and it is hoped that there will be a subcutaneous form of lecanemab available next year. The big advantage would be that people could be able to pick up their drug at the pharmacy and give it to themselves after they've been trained to do so under the skin at home. And so that would be a marked simplification of how we treat people. So lecanemab was studied in clinical trials that lasted 18 months against placebo, and it did not reverse the clinical picture of Alzheimer's disease. It did remove amyloid from the brain, and it was associated with a reduction in the amount of clinical slowing measured by a number of different ratings and scales. It varied somewhere between about 25 and 35% over 18 months, depending on the particular scale that was being used compared to placebo.
Someone asked, can you discontinue treatment once the protein is removed?
Pardon?
Can you, at some point, do patients discontinue the treatment?
It's a great question. So in principle, one could. If the protein has been removed, one can argue that there isn't a strong reason to keep treating. The company that makes lecanemab claims that their antibody binds to a particular form of amyloid that is still present even after the plaques are removed. The impact of all of this is a little bit unclear, and I think many of us would say we would like to reassess a patient after we treat and clear amyloid. There are some risks of treatment with lecanemab, as others on this panel have mentioned. One of the risks is that amyloid builds up in blood vessels in the brain as well as in plaques. It does so to kind of a varying degree in different people. And during treatment, in particular during the first few months of treatment, the antibody seems to engage with blood vessels, with some of the amyloid in blood vessels, and this can lead to a number of changes. Sometimes the changes are very minor. We see a very small hemorrhage or bleed that we can detect on MRI, but the patient has absolutely no symptoms. Sometimes they are a bit more consequential. If a blood vessel is damaged, there can be some inflammation or a slightly bigger bleed. People can have symptoms ranging from things like headaches, dizziness, sometimes a small stroke, in a few rare cases, impairment of consciousness. There have been a few cases described where people were taking anticoagulant medications or were given them because of a stroke. And in one person who was receiving lecanemab, this was catastrophic. So there's a strong recommendation to avoid particular kinds of anticoagulant medications. If we're treating somebody with lecanemab because of these risks, we will do a baseline MRI to kind of assess the brain, and then 3 safety MRIs during the first 6 months of treatment to see whether there are any of these particular kinds of side effects on blood vessels. They have a name of ARIA, amyloid-related imaging abnormality, because we can see them on MRI. And as I mentioned, we see them on MRI far more commonly than the patient is actually aware of them.
Thank you, Dr. Glasgow. I was told that my microphone sounds muffled. Can you all hear me okay? All right. I'm monitoring both the webinar chat and the Q&A. So for our audience, in the webinar chat, we're sharing resources and websites that we've addressed here in the forum. And the Q&A box, so there's two boxes, the webinar chat and the Q&A box is for you to ask your questions, which I will try to forward to the panelists. There have been a lot of questions about diagnosing and people with early stage of decline getting treatment. Are there any advancements for people with early onset Alzheimer's? I believe some of these new therapies are for people who have moderate stage. Who would like to comment or panel or talk about that?
Well, the new therapies really are approved for people with mild cognitive impairment or early symptomatic Alzheimer's disease. They really are not yet indicated for people with moderate Alzheimer's.
Okay.
And that is a very important area that's missing at this point, and that is finding a treatment for people who have moderate stage Alzheimer's disease. Because we really are focusing on people very early before any brain damage is done, but you know, the great majority of people are in that area in terms of having more advanced symptoms, and our treatment opportunities are really quite limited. So we really have a long way to go with that population.
And that's why I know the trials are so important. Someone asked if and I know that there are clinical trials that don't involve pharmaceuticals. Who would like to speak to that? Dr. Melina Henry?
I can speak a little bit to it. I think I always like to make the distinction of and I think this addresses some of the questions that you've seen pop up, the idea that we are looking at tackling dementia from a number of different angles. We're looking at treating dementia that now is symptomatic, and that might be an Alzheimer's type of dementia, which falls under the bigger umbrella of dementias. And then there are things that we can do to prevent or to mitigate our risk for developing the symptoms of dementia. And when we talk about reducing risk, we look at interventions like lifestyle interventions, behavioral interventions that may contribute to us regulating other comorbidities that exacerbate our potential or vulnerability to developing the disease, the symptoms of the disease. And so when we talk about those type of interventions, among those are included studies like the Pointer study, which is based in the US, is based on studies that have been conducted previously, and that have a lot of merit in terms of improving cognitive function and ensuring that individuals are remaining cognitively healthy. The US Pointer study, as I understand it today, is a multi-domain study where really individuals were encouraged and supported through exercise, as well as maintaining a healthy diet that was culturally relevant. And there are other components of it, like social engagement, cognitive engagement, and utilizing this multi-domain approach to test whether it can reduce the progression, reduce the risk. And so that study is still ongoing. I believe enrollment has ended, but the study is still ongoing, and those results will be coming up. And when we talk about behavioral lifestyle intervention studies, that is typically what we are talking about. I think those are incredibly beneficial. We haven't had or seen the randomized controlled study results that indicate that it is a disease modifying type of intervention, but in essence, it is a risk reducing intervention. And when we do that, we really are ensuring that we're minimizing the vulnerability of our brain to the insults of these other pathological manifestations or presentations.
I think a lot of people do want to know what they can do now and if it will help. And I feel like we answer this every year. can't help. And I believe that there have been studies that point to the fact that it can't hurt and it does help.
Absolutely. One thing I'll point out.
go
Oh,
ahead.
sorry. I was going to
No.
say one thing I point out that I was remiss in not mentioning. Sleep is a huge one, and I think it's gaining much more attention as the value of sleep and a full night's sleep, and also healthy sleep that has that where individuals go through the appropriate stages of sleep and allow for that brain healing to occur. Data continue to come out as to whether there are certain aspects of sleep that actually may reduce amyloid accumulation. The jury's still out on that. The verdict's not out on that. But I think that there is a lot of value to the evidence that is coming out and the importance of sleep and other behavioral interventions to cognitive health.
I'm terrible at sleep. I don't sleep enough. So yeah, maybe when my
If-
kids go off to college, I will start
If I
sleeping
could,
more. Yes, Dr. Sefji, I was going to ask you
Well, I just wanted to jump in. I think the evidence keeps pointing to the fact that the pathology in the brain actually starts 15 to 20 years before people become symptomatic. And that's a little bit scary, and it's also frustrating because even though these trials have been done in what we call mild cognitive impairment, honestly, most people, by the time we would label them mild cognitive impairment, they're already relatively impaired. I mean, I think our whole paradigm of how we view Alzheimer's dementia is going to have to change if we're actually going to do any interventions that make a difference early on. Because, as when the people wrote in the Q&A, I mean, it's currently primary care doctors do not have a good way to test if someone's got cognitive decline. There was a very old study that showed most people that felt that they were having cognitive decline really were having cognitive decline, whether we could measure it or not. And so, there's not an easy way now to currently detect if someone is starting to have problems. And even then, we know that the pathology is already fairly progressed. And so I certainly don't have the answers to that. And other than, some of these studies with the behavioral interventions, and I know more of the basic science work that the really smart people here are doing, hopefully we will get some better answers with that. I do, obviously we should all be doing things that should help us be more healthy, but I think taking care of your brain at any age is the best that we can do for right now. And I hope, so part of what I was going to say is I hope that eventually, we will be able to study different kinds of interventions that we can utilize earlier on when we have these more specific tests for telling us who is already developing the pathology. More specifically, we have things that tell us people's relative risk, but, not really specific, guess you will get it. And so certainly for any medication intervention, the FDA looks at it, what are you actually treating? Like if you can't measure symptoms, you can't, do a trial on it essentially. And so that's kind of where we're stuck right now with, we really need to be finding and treating people earlier, but the FDA kind of won't let you, like doing preventative treatment trials is a very rare thing. I'm not sure they even allow those at any point. So
As a matter of fact, we do have it. We don't call it a preventative trial because we're not quite there. But I think I'm glad to share this space with Dr. Plopper because we have been colleagues on this particular study, and that's the HEAD 345 study that tests the impact of lecanemab in individuals who are now asymptomatic. And where we've been able to forge a path to be able to do this is through the utilization of biomarkers, which is why this is such an important and exciting development in the field, is the ability to be able to find a signal for these pathological measures in the brain way before you have the clinical symptoms that we are much more accustomed to. And so that trial is ongoing and close to ending enrollment, which really points to the fact that we will be moving in this direction of being able to just point out and find individuals that have the biomarker evidence of the disease that are not yet symptomatic, and hopefully by treating early on, really mitigate or prevent the presentation of the symptoms of the disease. But in fact, as you've said very well, Dr. Sevci, these individuals already have presentation of the disease. And so our goal is to get to that disease presentation before those symptoms begin to take hold, which is now when other aspects of the brain are beginning to be compromised.
Do you want to elaborate on that, Dr. Plopper? Are your trials happening both in LA area and San Diego area?
No, our trials are specific to San Diego.
Oh, okay.
There are sites in Los Angeles for doing the lecanemab trial, but this particular trial is called the AHEAD study with lecanemab, and it's an interesting study. As Doris mentioned, these are people who do not have symptoms. These are preclinical. They're folks who either through a biomarker and then proof through a PET scan are proven to have amyloid. There later would be a tau PET scan. And then multiple MRIs for safety reasons. But what's been remarkable about this is the enthusiasm that people have shown for joining this study. These are folks who don't have anything wrong with them. They potentially could have something wrong with them at some point, but they have just remarkably enthusiastic and joining these trials, and also the retention of people. They stay in the trials. So they and their study partner, everybody in a trial will have a study partner, that's a spouse or sibling or friend, typically, who knows them well enough to report on them. And so both they and their study partners are extremely committed to this trial. So it is amazing for people who do not have symptoms, how enthusiastic they are in terms of joining.
Is there a minimum age, or is it just if you have that?
It was 55, and but that's now we're now ending enrollment for people 65 and over at the until it ends here.
Yeah, and so there were multiple sites. So as Dr. Plopper mentioned, he oversees he's the PI for the SHARP site, but there are sites in LA, USC, I believe Long Beach, and a few others in more northern regions. So but the study has been across 75 sites in North America. So individuals across the country have had the opportunity to participate, and it's really exciting to hear this as we don't interact with participants where I am, but it's always exciting to hear the enthusiasm that individuals have shared. I think it really points out what you've expressed, Marcela, as someone who has been a caregiver, as someone who has personal concerns about your own brain health with time. And I believe that these are the individuals that are really interested in finding a path forward where they might not see the future that their loved ones experienced.
I think for so many years and decades, it was, dementia and Alzheimer's disease is very unknown. And so just the advancements in the last few years is incredible. Dr. Chen, I wanted to circle back to something that you said in your introduction, where you compared it a little bit to like a type of cancer, where if you can kind of prevent those changes perhaps from happening in the first place, or if you can identify them early, you can kind of beat it. And I think, unfortunately, many of us are familiar with how we treat cancer. And I just thought I'd let you expound on that a little bit.
All right, this is a model for explaining the sporadic versions of the disease. So in thinking about neurodegenerative diseases, there are two general types. One is the familial that you've heard a lot about, but those are actually quite rare. So in the case of Alzheimer's, it might be just a percentage or two. In the vast majority, the rest of it occurs for no obvious genetic reasons. Now there are, I think you could call them risk factors, such as ApoE4 that you heard from Dr. Glasgow. And these do increase the odds, at least in some populations, but they may not do so in others. So that has raised the question of maybe there's something else that is taking place, including that what Dr. Sevci said about early types of changes. And these could be happening somatically, things that start to accumulate at an earlier stage before you actually get frank disease that's approaching. And you can think about this, and I simply use cancer as a way of, a common way of thinking about disease, that something happens in cells of, in this case, your brain, and by analogy to cancer in your body, that might be considered even precancerous or maybe pre-Alzheimer's disease. Right? For example, when you go in for standard types of, say, a pap smear, or that you're looking for precancerous types of cells, that something like that could be taking place in the brain. Now, there's a big difference in the brain, which is that most of those cells are what we call post-mitotic. They don't divide any further. They don't produce tumors, but they may have their own sequelae that looks a bit like a cancer. And what we and many others have found now is that each of these cells within a normal brain can vary at the level of its DNA sequence. And those changes are what many of us are now focused on to try to identify what they might be. And there's some evidence that some of the driver genes, such as APP, can be somatically altered, but it's likely that there are probably other genes as well that can be assessed or altered that way. And there are companies now that are looking at this mechanism from the reverse transcriptase side, something that produces changes via a messenger RNA intermediate. And so we'll see if anything emerges from that kind of work.
Thank you. Dr. Brewer, you've indicated that you wanted to answer some of the questions. There have been a lot of questions about brain injuries or traumatic or injuries to the brain or contact sports, and whether or not there's a correlation between that and Alzheimer's. Do you know anything about?
Sure, yes. So one of the questions that I probably should have typed in, it's a very quick one, so I'll just take care of it. Are there other PET markers other than fluorotaucipir? And the answer is yes, in the research setting, but not FDA cleared. So we have multiple at our hands for doing in our research. We use a tau tracer called MK6240, but it's not yet marketable. That's why it's got a number to it. And most of the other ones just have a number. So in clinical practice, just fluorotaucipir, and that one's not reimbursed either. So it's not really used that much in clinical practice. Okay, but back to chronic traumatic encephalopathy, which is the brain injury and neurodegenerative process that is kicked off through repetitive head injury. An area of emerging research, again, related to one of the bad proteins that is associated with Alzheimer's disease, but in this case, it is the tau protein that tends to build up after repeated neural injury. Very fascinating area of research. We, especially in relation to NFL, but even many other sports, even youth sports, of some concern of what even mild traumatic brain injury, and if it's repeated, might lead to an ongoing syndrome that's difficult to manage and treat. So we don't have therapies for it. We need biomarkers for it. One would think that the tau tracers would be able to pick this up, but when you look at imaging of it, the deposits of tau are not nearly as confluent as what you see in Alzheimer's disease. So it's very hard to pick up with tau imaging, but we'll keep working on it. Doug has some very exciting approaches that look at neural injury in general. There are blood potential markers, certainly CSF markers that may be relevant, but not yet ready for prime time. But again, stay tuned. Maybe that'll be a future date with a cure on CTE after we wipe out Alzheimer's disease. That'd be nice.
Be wonderful. Dr. Glasgow, did you want to expound on that?
Not much to add. We're still, looking, if people are concerned that they may have had enough exposures, that they may have CTE, we're interested in seeing them on a clinical and a research basis to try and see if we could collect some of the materials to support this research.
Dr.
And one would
Gonzalez,
need to be above age 65 in our study, right? I mean, unless.
I know it does seem like the minimum ages are, because I'm personally, I feel like I would volunteer for studies just because I feel like I know everyone has their own personal beliefs, but I feel like it'd be better to know than not know, just so I can prepare. But I need to like get a little older because I'm
Well, there'll be some. I'm only
eligible.
talking about our main longitudinal study.
Okay.
But if you do call our center, you enter our registry,
Okay.
and then you're available to be contacted when something you would be eligible for would come up. You just wouldn't be part of our yearly assessment longitudinal study without meeting those criteria.
I guess that's something all of us can do who are in the, who are interested. Is the first step is you have to sign up, and that's probably the hardest part, just making that a priority and taking the time to call the center and enter the database. But then after that, I know I've done some stories on places that have done clinical trials, and the participants I've interviewed said, oh, I was part of a list, and then they sent an email out and I read and I thought, oh, that might fit. So for anyone who's on here interested like me, we need to just take that first step and call our local centers. Okay, Dr. Gonzalez, we haven't heard from you in a while. We've been talking about a little bit about the changes that people can make now to potentially stave off dementia and Alzheimer's. What have you seen with your study with the Latino population, and some of the changes that you're trying to encourage them to make as far as sleep, diet, exercise?
Sure, and thanks for the question. But I do want to digress here just a little bit. We've heard a few times about the ApoE4 gene. That is a heightened risk factor, genetic risk factor for dementia, Alzheimer's disease. And I will just say we haven't really seen that amongst Latinos, Hispanics. That relationship is not terribly strong. And what we're seeing is that it may vary between different people, different groups of Latinos. So I just want to usher in a little bit of caution about that. What has been done in a largely white population, I would just say that 90% of this research, if not more, has been based on highly educated people of white backgrounds, the very willing, very motivated people that are highly educated and understand research. That other people, African Americans, Latinos, with maybe less education, different backgrounds, maybe immigrant, really haven't been involved in these studies. And I think Dr. Plopper was eloquent in saying this, is that we really need more involvement to understand dementias. Something that I read this wonderful article by one of our colleagues here on this call, and we had heard about these new tests being developed, blood tests and signals for that maybe Alzheimer's disease may be coming, that could get you into some of these exciting trials that you've heard described. But people of color don't necessarily test positive for these tests, and maybe underrepresented for these studies. So I think that's and Dr. Melina Henry, good job. I read your article with great interest, and thanks for doing that work. I think it's really important work, and it does seem to fit with the pattern we're seeing, at least in our folks are young, on average in their early 60s. So we're just not seeing a lot of the amyloid-like features in our Latinos. I think it was mentioned before, pathologic studies of brain, people who passed away. It's not just all about Alzheimer's disease. And when you look at the brains of several Latinos, not enough Latinos are involved in this research, but you see a bit of a slice for Alzheimer's disease, but you see a bigger slice for vascular dementias, changes in vasculature. We may be dealing with something a little bit different in our population. I can't speak about African Americans, but I would imagine there's a different constellation as well. ApoE, that risk factor gene, doesn't behave the same as it does for whites or Anglos.
That's so interesting.
Yeah. So I think this involvement of diverse populations is so important. Here we're in California, I'm apt to say, and 40% of us are Latinos. And to think that we are spending all these efforts and not include and a lot of money in these research, but in not involving this population really needs to change. And I think I'm not going to blame the participants or the would-be participants. I'm going to say we need to do a better job getting out the word and getting people involved in these studies. So I did want to say that. With regard to prevention, that seems to be our strong suit. We have been doing the sleep studies. We have been finding that optimal sleep periods are important. Too much sleep is not necessarily good. You think the more is better, but it's not. We seem to see that about 7 hours of sleep seems to be optimal. So I'm sorry, Miss Marcella. Maybe you might want to visit a sleep neurologist who could perhaps help you or do some behavioral training or the like. And for others out there, because sleep is a bit of a problem. Yeah, it's that darn phone. Put it down.
I get home from work at midnight. I work 3 to midnight. So like, and so
Wow.
it'd be like if you came home from work at 6 p.m. It's hard to just go to sleep. So I come
It's
out
very hard. It's very hard.
my email, and then this project, and then all of a sudden it's 3 a.m, or I hear birds chirping, and I don't sleep that much.
Tis the nightingale. But again, we've seen diabetes is a big problem amongst Latinos. It is it is. It affects a lot of Latinos, more than what we see in whites. And again, this is a fantastic area for prevention. I'll say preventing some of the vascular changes that may precede Alzheimer's disease and other types of dementias. Hypertension, Doug alluded to. These are all very targetable things. But even before you become hypertensive or diabetic, physical activity, these are all things your mother or grandmother probably told you about. And maybe I get to play that role today as grandfather here. But I will say that a lot of these sound bits of advice are applicable to the brain. And I'm apt to say that what's good for the heart is good for the brain, clearly, because the brain is so intricately vascularized that you need to keep that brain health and brain vascularization happy and healthy to maintain a good brain. So I hope I've answered your question.
Yeah, thank you. It's easy for a lot of us to be short-sighted, or for me to be short-sighted, but as you speak about being a grandparent, so my kids are graduating from college, so hopefully it's, several years before they get married, settle down, and have kids, but I want to be present for my own grandkids. And so, it is important for all of us to make those changes to our daily habits and our brain health, our heart health. Because from what I've learned from you wonderful doctors over the past few years is that it is all connected.
I think that's a pervasive notion, Marcella. Everybody wants to be around for their grandkids, for their great grandkids and the like, and to share in those experiences. That's why these sets of diseases, the dementias, are so terrible. We did a survey amongst our thousands of Latinos, and clearly 2/3 of people are concerned and worried about losing their cognitive function, their ability to function independently. This is a great concern of many, many people. So I think we're not alone, and that's why I think the great work of my colleagues here on this call, really, we're a bit of a team working together to find the cure and also find ways to prevent.
Yeah, thank you. Yes, longevity. That's what we're all striving for, and we don't want to be a burden. I don't want to be. Not that my mom was a burden. We loved her and enjoyed caring for her, but it would have been better had she not had, her cognitive decline. Okay, so what, I know all the panelists have been looking at the Q&A as well. Another question about type 3 diabetes. I feel like we've answered that there is a correlation. Can we talk a little bit about, I just think because it's so novel, the news yesterday with that new therapy. I know we opened up a little bit with it, Dr. Brewer. Can you just talk a little bit more about what that is and who may be eligible take that drug, how soon it'll be available.
Right. Yeah, I mean, we all don't know because the FDA process is its own process. They're going to have to develop their own label on this. But based on prior experience, that was the big hurdle, getting the vote that said, we all agree this should be approved. Now I think they're going to be off and running in developing the label, and not being the first, they're going to have a little bit of an easier path because, there really are not significant differences. There are slight differences, but I don't think statistically significant differences in terms of its effect size or its ARIA impacts. You'll see different percentages when you see it. And some people will say, oh, I like this one because the percentages are slightly lower. But I think if you actually look at the differences in the trial, that is basically, my view, going to be negligible. And you could pick either one of these two. So others might disagree, but we'll see what the label shows. The concept of, again, being able to say there's an end period where, hey, I've removed amyloid, let's go ahead and stop. This is going to be a benefit, but the entire field is going to be shaken up if subcutaneous administration is available instead of infusion. So we are excited about these new tools. Finally, it gives us a nice way, even if you don't believe the concept, oh, these benefits don't outweigh the risks. The risks are significant. The benefits are small when you look at the curves. My view is that it gives us a toehold to do more research. It allows you to remove amyloid from the brain, look at the remaining proteinopathies that Gerald talked about, and say, well, how much of a factor are these other proteinopathies? There was a question about late and why is it not getting a lot of attention? Well, maybe because the name is such a mouthful, this limbic associated TDP encephalopathy, that is a different proteinopathy that tends to happen in people of very older ages. It's likely there in many of these mixed dementias that are taking place, vascular diseases in there, synucleinopathies, the Lewy body syndrome is there. How much of that is explaining the continued decline of patients in these trials after amyloid is removed? That's going to be an area of active research. We're very excited about tackling these problems with Doug's partnership with his amazing new biomarkers of these other illnesses, so that we can do personalized approaches and say, well, this person did very well because all they had in their brain, it's a rare state, but all they had in their brain was Alzheimer's. The vast majority have many other proteins going awry, and that's why they continue to decline. So now let's start tackling these other proteinopathies. I think it's going to be a very exciting time going forward.
There have been some questions, and I often wondered this with my own mom, but there are so many moments of clarity along with so many moments of confusion. And I think what those of us who don't study the brain wonder is, do you know why that is? I kind of see it as a puzzle, and the pieces are just kind of missing at random times. She may know this one day, but then not this the next moment, but then remember it again. I mean, it's just a little bit confusing for the caregiver.
I mean, I just spoke, but I'll talk again just because it's fluctuations are a factor that we look at. It may signal a different illness when there's marked fluctuation, but it's something that we evaluate in the clinical setting to understand what degree of fluctuation is. A lot of times families think, oh my gosh, how could they have Alzheimer's? They are able to tell stories of their childhood, no problem at all. So there's nothing wrong with their memory. Well, that's a feature of the disease. The disease is affecting a structure in the brain that is laying down new memories. So they may be able to tell stories of their past with quite a great deal of clarity. But if you ask them what they had for breakfast or what just happened, or they may repeat questions, those are the signals that are suggesting that the structure called the hippocampus is malfunctioning, and it's one of the first sites of damage that is seen in Alzheimer's disease. So that may explain some of the confusion of why is the person so clear in this state and not so much in the later state. many other factors, the sundowning question that was talked about here, the sleepiness, the lack being in an unfamiliar environment, all of those things impact the degree of clarity that you're going to see in a patient with later stages of the disease.
I feel like we've answered most of these, or you've done that individually. And I know that in the past we've taken a photo of all the questions just to make sure that they all get answered. If you don't mind taking one last look while someone else is speaking, but I do want to, we have about 30 minutes left, and I guess I just want to give each of you a chance to make some final comments about what you hope to see in the next year between now and our next date with a cure. And some of the questions, you know, we've discussed: what prevents dementia? Are there drugs in the pipeline? Besides, are there more PET biomarkers that detect tau? I mean, a lot of really insight, a lot of people out there that want to know all these answers. And so maybe if you could each just wrap up what you hope to learn in the next year, and what people should just be, you know, at top of mind as we move forward. And why don't I start with, well, no, I'm not gonna, you're retiring, so I'm gonna keep you for last. Let's start with Dr. Brewer.
Okay, thanks. I wanted to correct something. I mentioned, you know, I've talked so much about our collaboration with Dr. Glasgow with his markers, but we have collaborations throughout this group. Gerald's been a fantastic partner. His new roles within the really exciting industry of San Diego is very exciting to us. I think it's going to really bolster our impact throughout the entirety of this field. The San Diego is a true powerhouse in fighting this disease. Our partnership with ATRI, Dr. Melina Henry, we've got an incredible transformative philanthropic gift that enhances our collaboration between UC San Diego and USC, traditional rivals, but we're coming together because this disease is so important that we need to tackle it together. San Diego State, one of the great partnerships that Hector Gonzalez has is through that Study of Latinos program, which San Diego State has a great program in, and Sharp and all this group has been very, very powerful in working together in the San Diego community. So that's what I'm most excited about. I'm excited about the fact that we're situated in a location that is unmatched for doing, for pushing this field forward. We work closely with the Salk Institute on a topic that I didn't get to address, but I'll go ahead and address it now since you gave me free rein. The new markers of the new models of the disease that are allowing us to go beyond the mouse models of Alzheimer's disease. I always say we've cured Mouseheimers many times over, but we haven't cured Alzheimer's. Well, one of the steps that's going to allow us to do this progression of research on this human disease of Alzheimer's disease is the ability to look directly in human cells. So one of the things that we're working closely with the Salk Institute is in taking skin fibroblasts and turning those into neurons. We've talked about it in prior dates with a cure, but we now have a new scientist, Jerome Mertens, who can directly transform those cells into neurons without going through this younger stage of neuron, which takes away the aging impacts. So I'm most excited about finally being able to get where aging leads to the disruption of these molecular pathways. And it may be through the energetics process, the mitochondria, the failure of adequately using glucose to handle all of the pathways in the neurons. We're going to get after that target using these direct transformations of skin biopsies. What does that require? It requires human participants. It requires the audience here, if they're willing to come get involved in clinical research and do something that's maybe a little bit less comfortable than a blood stick, sometimes a lumbar puncture, sometimes a skin biopsy, but it really is critical for pushing forward our science, and especially in the less represented groups such as Latinos. We put our entire center to be cross-cultural, bilingual, and able to address additional concerns that our Latino partners may have when they participate in a study. We've set a satellite clinic down in our satellite research center down in Chula Vista to make it easier to connect with us. And there's going to be a lot going on before next Date with a Cure. So we're excited to share that with you next time.
So wonderful. Thank you. Dr. Melina Henry.
Yes, thank you.
Next year.
I have a long wish list, and I don't know that it will be accomplished within the next year, but I can say that my hope for next year and the upcoming years is to see much more inclusive science. I would like to see much more inclusive cohorts in our trials. I think that diversity in the science, enriches our findings, enriches our understanding of disease, but enriches our ability to target disease. Thank you, Dr. Gonzalez, for the shout out. I think it gives us the opportunity to do amazing work to really get at true sources and causes for disease, but also points as to where we can increase and improve access, which in turn informs our approaches toward inclusivity. Our hope is that we can continue to use blood-based markers to screen individuals who participate in studies, that we might be able to find other biomarkers that allow us to identify other disease, other contributors to symptom presentation, that we might continue to move earlier and earlier so that we might see less and less people developing the symptoms of Alzheimer's disease, and we can get to true prevention. Those things get me excited for the future.
I feel like finally we're making advancements with these therapies. Dr. Sefji.
I too have a very long wish list. I think everything that Dr. Brewer and Dr. Melina Henry said, I wholeheartedly am excited about. And I think what excites me the most is the fact that we're finally getting to be able to understand the pathology of these diseases a little bit better, that will then lead us to more targeted treatments. It used to be, dementia was just one big category, and we didn't have great ways of separating out what was going on. And we've made so much progress in terms of figuring that out. And then these guys on the panel are doing the science that needs to be done to really pin that down. And again, I think that will lead us to better treatments in a sort of simplistic way. And I know Alzheimer's San Diego is a great resource, and they can really help folks. But I would wish too that primary care doctors would be better educated about being able to know when to intervene, how to intervene, and helping patients navigate this new world where there are treatments that may be disease altering that should be started as early as possible. I think there's a lot of work that needs to happen with educating, especially our primary care doctors on that. But, I know that the meds are out there, the science is progressing, and, I think it just feels like it's sort of exploding. Having been part of this for several years, the pace of development just seems faster and faster, which is incredibly exciting. And I'm just thrilled to be part of it.
That's great. Pace is exploding. I'm taking notes. That's what I am feeling, right? You've all been so wonderful. You can't see. I feel like every year we get closer and closer to it being like a hope and a dream, but actually, seeing some progress. Dr. Hector Gonzalez, share with us some of your hopes for the next year.
Gosh, I'd like to catch up on my emails perhaps, but aside from that, and my hope is that my citrus trees will do well and produce for a change. So in this mess, I hear you, does gardening help? It's certainly not going to hurt.
I saw that too. Yeah. It's like,
I think anytime you're engaged, you engage your mind and your body, you're doing something good for you. So what are my hopes? I've been working with a group of people from around the world to understand, to gather information about what we know about Alzheimer's disease and related dementias, and I'll underscore the related dementias, And I'll also say that I think what we're seeing is perhaps a time for a shift in the paradigm from a purely Alzheimer's disease focus to a more comprehensive view of dementias, which affect so many people and may manifest in other folks too. So if we can get that out, I think it'll do something important for where we move, where our next steps will lead us as a field. So I think I'm banking on that, and I'd like to be able to get out some of the thoughts that I've had about how Alzheimer's disease and pathology gets in your head in the first place. And so that's something that I think may have some influence on the field, and how may get us towards a better, more comprehensive understanding of dementias amongst the whole population.
Thank you. Yeah, I see a lot of efforts on your part and a lot of the panelists here for more inclusivity. And I know Asians, in addition, are pretty just culturally not comfortable with stepping up, sharing personal information. So, I know it's a challenge among many minority groups. So I thank you all for pushing for that inclusivity. Dr. Gillespie, hello. If you could, I feel like you always have so many things that you're working on. I would love to hear what you're most interested in for this next year.
So again, in the clinic, I think I'm going to be very interested in seeing how the new anti-amyloid therapies roll out. Something I would love to see would be, so we've talked about blood tests for when amyloid might be present. It would be terrific to have a blood test that lets us know that amyloid has been effectively removed. At the moment, that's going to be an important tool that we will need in the future. And at the moment, the only way to try to determine that is through doing an amyloid PET scan, which is a great anatomical picture, but it's expensive and inconvenient. As I mentioned, I'm interested in other dementias and sometimes their interplay with Alzheimer's. I think I'm looking forward to seeing efforts at clinical studies and clinical trials that look at combination therapies for Alzheimer's and other disorders. And we're starting to see a little bit of effort in this regard. A combination of amyloid and tau therapies is being started in some people who have an inherited form of Alzheimer's, and hopefully we'll see more progress and traction in this area that will kind of relate to other people with Alzheimer's and with these mixed pathologies.
I know you always tell me that can you remind me again what the inherited percentage is? I don't know how to properly.
So there's inheritance and inheritance. The strongest inherited forms, Dr. Chan had mentioned this before as well, are called autosomal dominant Alzheimer's disease. This is maybe 1% of everybody with Alzheimer's. And these are people who have genes that will definitely drive Alzheimer's disease. In some of the most severe forms of these, people will develop Alzheimer's in their late 20s, but somewhere from onset around that age to onset around 50 or so would be the range to expect with some of these really strongly inherited genetic factors. And then we've heard a lot about the apolipoprotein E4 gene, or ApoE4. This is a risk factor gene. If you have one copy, your lifetime risk of Alzheimer's increases about 2 to maybe 2.5 times. If you have 2 copies, however, your lifetime risk increases about 10 times. And so people who are double carriers of E4, again, it's not absolutely inevitable. There are some people who live happily into their 90s and are E4, E4s, but there's a definite increase in risk if you're an E4, E4. And otherwise, genetics plays some kind of overall role in Alzheimer's in general. And Dr. Brewer has worked with others on trying to put all of the genes together into something called a polygenic risk score. And there's going to be a lot of work in that area as well to try and see if we can improve risk prediction. We have a way to go still.
That's interesting. Thank you so much. That's interesting to me. All right, Dr. Chen, what are you most excited about for this next year?
Well, I think that our panelists have touched upon almost everything already. I want to underscore what Dr. Brewer said, which was that San Diego is truly one of the epicenters for research and for advances in both neuroscience and the neurodegenerative diseases like Alzheimer's. So I think keeping an eye on what's going on in the community here, ranging from the basic studies all the way up through the clinical and commercial studies, is a great thing to acknowledge and appreciate. And as I think developments occur, I think San Diego, as well as Alzheimer's San Diego, should get credit for that, and that we can all be proud for the types of advances and achievements that are ongoing. And the next year will no doubt produce more of them.
Thank you. All right, Dr. Plopper, some thoughts. You'll be on a, I don't know, golf course, yacht on the ocean in a year from now. But what do you leave with your team there as you retire?
Well, I've been doing clinical trials for a long, long time, actually since the early 90s, and did the trials looking at donepezil, galantamine, rivastigmine, those other medications, Namenda. And also in more recent years, the efforts at finding a monoclonal antibody to address amyloid, and that included other medications called, or drugs called bapineuzumab, solanezumab, big campaigns that were done by multiple pharmaceutical companies to try and get here. And those were failures. And my thanks go out to the many thousands of people who participated in those trials, many of whom had moderate dementia. And it sort of led to the lessons learned that we do need to deal with this disease early on. But it's been very gratifying the last few years to be a part of studies that are actually leading to disease-modifying agents. We're finally here. I've been a geriatric psychiatrist for 40 years and dealt with an awful lot of people with Alzheimer's disease, and finally can speak to them with some degree of optimism after all this time. So it's an exciting era. I think the next year it's really going to be a matter of operationalizing these two drugs, lecanemab and donanemab, and getting them out to the public and finding out the problems in access and the problems in assessment, and also the actual execution of these, actually getting these delivered to people in a proper way, and also side effects properly monitored. So it's going to be an interesting year in terms of that becoming operational. So thank you everybody for letting me participate in Date with a Cure for the last, I don't know how many years, many years. And it's been a lot of fun. Thank you, Alzheimer San Diego. Thank you, Marcella, for hosting this, and also for your great interest in this. And Alzheimer San Diego, what a fantastic organization that really, I think, is still somewhat underutilized by people with, with Alzheimer's disease in this community. I think there needs to be a greater understanding of just how valuable what Alzheimer San Diego does. And so thank you.
My co-anchor Carlo Cicchetto was involved with Alzheimer's San Diego after his father was diagnosed with Alzheimer's disease and passed away. And so then when my mom was diagnosed, he kept pushing me and nudging me to contact them. And that is the hardest part, I think, for a lot of us, is that first step, making that call, whether it be making that first call to Alzheimer's San Diego or making that first call to sign up and be part of a clinical trial database. Just sitting down and making that first call is usually the biggest roadblock. And I'm just so grateful for Carlo for turning me on to Alzheimer's San Diego, which keeps, all of its money local and offer so many free resources and support for the caregiver and the family, in addition to the patient. So I echo your thoughts, Dr. Plopper. And I just want to, on behalf of Alzheimer's San Diego, we want to thank you for all that you've contributed to the community and to partner with Alzheimer's San Diego for all these Dates of a Cure. I know you're all Days with a Cure. All of you are very busy, and to take the time every year and be reflective and looking forward to things that we can do together as a community to help support the efforts and the research. It's wonderful, your time and commitment, Dr. Plopper. We want to thank you for your research, your participation in this event, and really your support for Alzheimer's San Diego over the years. And it's just really wonderful. I'm looking at the time, and every year the 2 hours go by so fast. And it will be great when we come to a point where we don't have to have a date with a cure because we've already found the cure, or maybe we could have a shorter forum. But I feel like there are always so many questions. And anytime I go anywhere and people in the community talk to me, they always mention my mother, and they always have a story about their loved one that also was diagnosed with Alzheimer's disease. And I remember when my mom was first diagnosed, and people would tell me, oh, my mother or my loved one passed away from Alzheimer's disease. And I couldn't grasp how that would happen. And they said that eventually the body just, you don't remember to breathe, or your systems just shut down. And so until the end, I was fortunate. My mom never forgot who I was, because it was something else that took her. But I hope that nobody has to go through that, because from the experiences that people have shared with me, it's like a cruel way to kind of leave this earth. So I thank all of you for your dedication and commitment to finding a cure. And I love that this title is Date with a Cure, because one day that date is going to come. All right. Well, we are nearing the end of the event, and we have to wrap up again. And I want to thank again all of our panelists and everyone that took time this morning to join us on our Zoom webinar. If you would like to learn more about local research and how you can help or get involved, contact Alzheimer's San Diego. They're so friendly. Just dial that number and you will be in. I know taking that first step is difficult. And remember that Alzheimer's San Diego's team of local clinical care coaches is also here to help, and they're marvelous. If you are in need of more information and support and want to talk one-on-one with a social worker, in the chat box, you'll see a link where you can request a follow-up with one of their clinical care coaches for more information. So again, before you leave, peruse that webinar chat. I know that Alzheimer's San Diego, if you're registered for the event, is going to send out some follow-up information. But if you have a phone, you can kind of take some screen grabs of the links there. Fill out that form. Oh, there's a form. Oh, look, request for follow-up. See right there. Fill out that form. If you'd like more information about research or any of the free services provided by Alzheimer's San Diego, you'd like education, the virtual support groups, ALS companion visits. My mom had a woman who's going to be our family friend for life. Once a week, Claudia would come and visit with my mom for about 4 hours. And my mom felt like it was her best friend, because it's difficult for people who aren't knowledgeable about those diagnosed with Alzheimer's to carry conversations with them for a 2 to 4 hour period of time. And Claudia was so patient and kind and knew exactly how to redirect my mom, and would do gardening with her, would bring little succulents to plant. So the ALS companion visits, they're free. They're wonderful, great resources. I would encourage you, if you have been diagnosed with Alzheimer's or dementia or have a loved one, those visits were invaluable and priceless for my mom. Once again, thank you to our amazing panel. I can't thank you enough for sharing your morning with us, and thank you all for coming. I hope you have left with more knowledge and more hope about the search for a cure. And one day I hope this date with a cure actually comes to fruition. All right. Thank you, everybody. Appreciate you spending your morning with us. Goodbye. And thanks again to Alzheimer's San Diego and Sharp for giving us this great morning.